now we come back and say, okay, what if we're in ophthalmology? And we just want to focus on the eye socket, or emergency medicine, like I said. These are the bones that make up the eye socket, which of course include a lot of the other ones we already talked about. But now we're just saying, yeah, but this is the orbit. And this is definitely one you want to know, not just for me, but for ophthalmology and ER medicine. As they'll bring this back up, and you'll look at, as we're going to do, which ones form which part of the wall. So that's the part to get. The list isn't as important as, well, I guess it is, because if you don't know them, you'll never know the walls. But it's knowing which one's the lateral wall, medial wall, because it's an orbit. It doesn't really look like that, but it's a textbook classification. So maxillary frontal, or zygomatic ethmoid, lacrimal, sphenoid, palatine. We've already talked about all of those. We also already mentioned, but we'll go back and say, well, if you say, well, what foramen or structures are around this socket would be important? The optic foramen, where the optic nerve goes through, superior orbital fissure, where I know everybody already knows, but that's where B1, B2, B3 go through. I'm just being a little sarcastic. I know you aren't really looking at it as much. But we did talk about the yesterday. The inferior orbital fissure, I said, it's there, but we're not really bringing it up at the moment. Then you have the supraorbital foramen, that's above the eye, and then you have the lacrimal fossa that helps us to identify where bones are in that socket. So this is what it kind of looks like. I changed this picture. I used to have it in just black and white, and I kind of drew it out, but I liked this one. The only thing I didn't do is go and line out some things. At the bottom, I've listed kind of my way to remember that. Right? The roof, the lateral wall, the floor, the medial wall. But the picture I liked, the way it was color coded and it was set up. The point or what I'm trying to point out is, I just care that the zygomatic bone is part of that. I care more about that you're studying and knowing this, not that it's the zygomatic process of the frontal bone. Because we certainly didn't discuss that yesterday. Right? We talked about the zygomatic process of the temporal bone making up your cheeks. So this chart gets a little more specific than we need to. So just stick with what's at the bottom. Clear? So the roof, by definition, consists of, say roof, we're talking about up here, in fuchsia, or pink there. These aren't going to be exact here. This is the roof. So you have part of your sphenoid. The sphenoid is what you see at the back of the socket there. And then you have the frontal bone. The lateral wall, this is our zygomatic bone. And once again, that's the sphenoid here. So the lateral wall is over here. The floor, by definition, is part of the maxilla, the zygomatic, and the palatine. So the floor, kind of here. Now you can't really see it. Remember I told you the palatine is part of the eye socket. The top of the inverted L or T, however you like to look at the palatine. And it comes up and makes its presence right here. That little piece is the palatine. And then the medial wall has maxilla, lacrimal, ethmoid, and sphenoid. So all of this is kind of the lateral wall. So when you're going through these, use what's at the bottom for the diagram, okay? And that'll tell you which ones are part of it. Guarantee it'll come back up, especially in ER. Looking at like orbital fractures, entrapment of eye muscles, blowout fractures. I've never had a patient with a blowout fracture. I'm waiting. Like blowout fracture, you blow out everything. You can reach in there and put your thumb in the top of your mouth and move this whole area forward. It doesn't sound like it would hurt them, but I'd just be cool to do it once. I'm not looking. I don't want him yelling to have blowout fracture. All right, sutures. We got to hold the skull together so we have sutures. Coronal sutures. I missed it. What? Coronal, sagittal, lambda, 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 and squamous. If you don't know what that means, it's lambdoidal, but So sutures, we're going to name a few, not all. We're going to name the ones, the most common players that people will discuss, and the larger ones. And so you have a suture that is coming between the parietal bones. And that is called the sagittal suture, just like we had a sagittal view, right down the middle, sagittal section. And then you have the lambdoidal, lambdoid suture. I ruined it by making fun of animals, or no, the nerds. Okay. Can you not say that word anymore? I mean, I'm a nerd. I read all sorts of nerdy stuff that y'all know. Of course, y'all are busy right now with my field. See how I work that in? I had to quiet myself down. Okay, so that's your lambdoid suture. The only other one that we're really going to look at is on each side, and that's the coronal suture. Sorry, there's two more. I was thinking about the squamous suture. So the squamous suture is where we start to see, well, aren't there other sutures? Yeah. Squamous suture unites the parietal and temporal bones. And then you have the coronal suture, it's coming all the way across. Like when you think about planes, this is the frontal plane. It's also called the coronal plane. So it's just recognizing those four and what they connect. Like I said, there are others. So we've been waiting on you. Glad you made it. I'm just, you know I don't think.
201 persons.
You did them? You ain't got one. You didn't have to tell me that. I didn't know your personal information. It's hard not to say something because you got to come all the way up to the front row, you know. So I know you appreciate it. You give me a hard time anyway, so that's what that's about. Sagittal suture, if you couldn't see them on the others, coronal, squamous, lambdoid sutures. How we connect the skull bones. In children, these are still open. They don't fuse until a little bit after birth. And we all know that. We talk about the soft spot on the head. So generally when somebody says, hey, you're feeling the baby's soft spot up there, that's the anterior fontanelle. But there is also a posterior fontanelle. And then on each side, you're going to have an anterior lateral and a posterior lateral fontanelle. And so if you think about a baby's head, it's pretty big. I mean, think about childbirth, which is amazing that that head goes through such a small area. Unfortunately, I don't even want to think about that when it comes to me or anything, but baby's head's got to go through there, so it kind of comes out deformed, right? If you've ever had a child, and the first look you look at it, you're like, whoa, what happened? What happened there? And it goes back to the normal shape fairly quickly. Get a little cone-headed looking to them. So those are your major fontanelles, and of course they're going to ossify and close and seal, but it's allowing the baby's head to modify as it goes through that birth canal, but it also is permitting the rapid growth of the cerebrum or brain during infancy. It's still growing. Remember, neurons were made very, very, very fast, and then you go back and they're still being made, and then you go back and myelinate those later. And so as that's growing, it'll allow it to expand up until when they fuse. So we talked about that with like hydrocephalus, how that allows that head to get bigger. We mentioned them as we went through the bones, but in 4 different bones, we have what's called the paranasal sinuses. And these are cavities or openings within that bone that helps to lighten the head. If you didn't have these, the head would not only be heavier, but you also would not have the ability to, you can filter out things, trap stuff with mucus. That's why your sinuses sinuses can get infected. It's why when your sinuses are full, because they do resonate sound, you can't, and they don't sound the same, because you don't have that space for that speech or that air to move. It's all clogged up. So going back to yesterday, we had the frontal, the sphenoid, the ethmoid, and the maxillary sinuses, maxillary sinuses, and this is what it looks like. So if you kind of use the right side first, you can see you have your frontal sinuses, and then you have your maxillary sinuses. The maxillary and frontal sinuses are what almost all sinus infections, you know, you've ever gone in to have a sinus infection and you say, have you lean over, like you're sitting, you lean over. It's a classic sign, like if you have fever and you have increased pressure and pain when you bend over in your face, it's probably a sinus infection. Not always, but suggestive of that. We don't generally complain about them, but you can actually reach your ethmoid sinuses. You know, if you're sitting here massaging, you're actually on your ethmoid sinuses. You're not going to get back there to your, I've had a headache so bad from sinuses before, I felt like I was trying to reach my sphenoid sinuses, but I'd get pretty far back there. Anybody ever had one of those headaches? Just felt you could rip your eyeballs out. Somebody probably had one today. But they're here anyway, and that's good. That's good. Okay, muscles of mastication. I don't have anything funny to say. I run out of funny things to say the longer the semester goes on. You already know me. The only thing I can do is talk about my life. I can say, well, yesterday I did what I dubbed, because the sun was killing me. I did Operation Kayak Rescue. It's been on my list for like 2 years. To go down to the pond and resurface kayaks. We got a bunch of kayaks down at our pond and a big paddle boat. It was all flipped upside. I don't know what happened. It looked like a war zone down there with the kayaks. Anyway, that's what I did yesterday. Went home and rescued kayaks. And then swapped the rotors and brakes on my wife's truck. And I went to bed. Took me longer than I thought. We were talking about that. Because I should have replaced the calipers too. I mean, I know y'all often don't care, but the look of not caring in y'all's faces right now is unpalatable. I can feel it. I can feel it. I told you in the beginning that we're going to get to know each other, but most of the time you get to know more of me than you, so. But I could feel it. I mean, it was just heavy. But we got to have a break sometimes. Anatomy gets really boring, like I say, every now and then. Okay, muscles of mastication. When you look at the muscles of mastication, we're going to look at which muscles actually help you do which action of moving your mandible so that we can talk, chew, whatever that might be. These are going to include the masseter, temporalis, and then our pterygoids. Most of these are going to arise off of the skull and insert on the mandible, and they're going to be innervated. If you go all the way back to your cranial nerves, remember we said that cranial nerve 5 innervates the muscles of mastication. And so this is where we see them. If you're talking about the mouth, we use some terms you don't use in other areas like protract and retract. So when you talk about protracting or retracting, you got to think about the mandible. If we take our mandible and we bring it out, so just break it. That's protracting and retracting. That's what they're talking about. So you can protract and retract. You can elevate and depress. If you elevate your mouth, you close it. If you depress your mandible, you're opening your mouth. And so temporalis and masseter are responsible for elevating the mandible. Like you're going to bite down. That's why when you clench your teeth, your temporalis up here, and you can really feel your masseters when you do that. The temporalis also helps retract. If you look at how it's set up, this is temporalis. And so its pull is going to be this way. So yes, it's helping to clench down, but it also helps to retract that mandible somewhat. The pterygoids are a little bit harder to see because they're kind of deep to these. So you have to remove masseter. This is temporalis, lower portion, here's masseter. and we reflected them back, and on each side, going to like the ramus areas of your jaw, you have medial and lateral pterygoids. Does anybody remember where these may have, not that you have to know origins, but anybody know where the pterygoids originated from? We mentioned it yesterday. The sphenoid bones. Right? Remember when we talked about the sphenoid has some projections for the pterygoid muscles? Well, they come off of there. That's something you gotta memorize. So the lateral pterygoid on each side is going to help to protract the mandible. It can bring it forward. And it also helps to depress the mandible. And so if you look at all four of the muscles of mastication, this is the main one that helps to depress the mandible. The medial pterygoid is responsible for elevating and protracting. So combination of these is going to allow you to move your jaw, because you have two on each side, and as they work to elevate and depress, protract, retract, they're accompanying you, like if you picture a grinding motion with your jaw. The way you're going to remember these is that when you start to say, for most people, when you say lateral, right, when you say lateral, you start out with your mouth open, lateral. When you say medial, you got to kind of emphasize it. Medial because it is going to elevate the mandible, which closes the mouth. So in order to say that M, medial pterygoid, lateral pterygoid. Kind of got to emphasize it when you say it so it makes sense. Then we get to some fun stuff. Muscles of facial expression. Jim Carrey's who I always think of. He can move every single muscle of his face. And you can too. You may not be as famous as him, but you can too. If he had to have just stared into a mirror like 24 hours a day for years and years. I don't know how he does that stuff with his face. You could too. It's like everything in life. It's just do you want to? It's the way I view everything. There's nothing I can't do is do I want to. Anybody agree with me? You ever get halfway into something and go, what am I doing? Muscles are bad. That's true. It's not like an arrogant statement when you say, I feel like I can do anything. That's the reality because everybody in here can do anything they want to. There's so many people say I can't. My kids are not, I told you that before, my kids aren't allowed to say I can't. It may be challenging and at some point it may need help, but I can't do it. And so can you. I hate when people say, I can't do that. Why not? If it's important, you'll figure out how to do it. That's just a fact. You got here. How many people told you you can't go to PA school? You'll never get in. Never. 300 people, they take 10? I'm saying not natural guard. That's what you hear out there. You'll never go. You never get there. And now you got the sheer joy of being here. Doesn't feel like joy when you're going through it, but it sure does when you finish. Okay. Muscles of facial expression now are interesting because we get to look at what muscles do what action. As we go through them, what's important? Not the origin and insertion. Even when I taught origin and insertions for testing purposes, I didn't really test these because a lot of these muscles of facial expression tie into each other. And so what I want you to focus on with the muscles of facial expression is if it says it does an action, that's the action it does. I want you to figure out what muscle does each action. And so when you say I'm smiling, which muscle is responsible for bringing the sides of your mouth laterally, superior and laterally? We're going to look at that. And then pay attention to which branch of the cranial nerve. Cranial nerve 7 innervates all the muscles of facial expression. So all of these are going to, if someone's asking you which nerve or branch, nerve and branch are interchangeable. Which nerve innervates this muscle of facial expression? And if you had, well, there's cranial nerve 7 in your answer choices, and then there's mandibular branch, or mandibular nerve, or just mandibular, because you already put nerve in the stem, right? The question. Well, the correct answer there is the more specific branch, which directly innervates it. Makes sense? That's the same way with a lot of nerves, but they're always looking at what's right before, what actually innervates it. We'll see what I mean here in a second. If you were to take this individual's hand, I don't know why you gotta come around your head to do this, but I guess so you're not covering their face, I don't know. So you have the temporal branch, guess what? It's up by the temporal region. The zygomatic branch, over the zygomatic process. You have the buccal branch, which is your cheek. Then you have the marginal mandibular, or just mandibular. I normally just say mandibular. The only reason you say marginal mandibular is to make you remember that which cranial nerve also has a mandibular division. 5. That's why. And then cervical. Down there on the neck. So that all makes sense. Each one of them, and sometimes a muscle might get innervation from 2 of them. You can use this mnemonic here to Zanzibar by motor car. You know, I can't get out of telling things because I had a student, and I need to quit saying it. It was like 5 years ago. Came in and said, I don't know how I missed that question. I was reading through it and looking at it, and I knew the mnemonic, I knew it. And I'm like, okay, let's pull it up. And as I'm pulling it up, it said, nah, to Zanzibar by motor bus. I'm like, no, that wasn't it. That's why they missed it. They changed car to bus. Well, maybe because I'm not getting on, I know it sounds so negative. Unless I have to, I'm not getting on public transportation. I just don't like public transportation. I'm going to drive. Actually, if you say let's go somewhere, either I'm driving or I'll meet you there. It's just I'm not going to be there without my car. I know, I'm telling you those things, it makes me odd, but anybody else like that? I'm going. Probably because every major accident I've been in, it's always been somebody else driving. I gotta watch out on the way home now. That guy put me through a windshield once. My goodness. Okay, occipitofrontalis. That's one thing you'll always know. Anybody broke their jaw? Your jaw breaks, there's no doubt. No doubt. Your teeth are all that was a fun time. Occipitofrontalis is a very large muscle. It goes back to looking at when we talked about the aponeurosa. Right? This is a great example of it. It's on the back side. You're going to have, it's called occipitofrontalis because you have an occipital belly and a frontal belly. And they're going to, if we talk about origin and insertions, it's going to be where the muscle starts connecting to this aponeurosa. So to give you a visual there of what we're saying on the screen is the origin, once again, you don't have to learn these origins, but it helps to go through them. The origin of occipitofrontalis has an origin at the occipital bone. I'll always try to write O's and I's. So that's saying that's the origin. And then in the frontal belly has an origin on the Galea aponeurotica, or that covering, that white covering there. And so then you have to have 2 insertions, and so the occipital belly inserts at the Galea aponeurotica here, and then the frontal belly of this is going to insert just superior to the eyes, down in here. It's going to tie into other muscles. And so if you were to tighten this muscle, that's going to help raise your eye, your wrinkles, your forehead like you're surprised. And it's bringing them up. So you can raise your forehead. It also explains why when you have like suboccipital, and we're going to talk about those muscles, you have suboccipital problems. You're studying your micros too much and stressing at the same time, and you get that band feeling, your head starts to feel tight, you get that frontal headache. And it's because all this is tied together, and when it gets tight in your neck, it starts pulling on this muscle back there. If you're having those stress headaches. So if you have a band around your head and it's hurting, well, that's generally a stress headache. You work on your neck, relax some, take some deep breaths. That doesn't work. Relaxing this. Get you a suboccipital pillow. I'll explain that under the occipitals. The innervation for occipital frontalis. With all of these, look at where the muscle is. Where's the muscle? It's up top. Right? And if you know the branches from when we talked about them as cranial nerves, that's up by the temporal region. Well, let's see if that fits. Yes, it's cranial nerve 7, but specifically it's temporal branch or temporal nerve. Zygomatic is major and minor. I put together here. Both of them originate off the zygomatic bone. We're going to look at a lot of times where they insert so we know what they do. And major inserts at the skin, along with a lot of other muscles. It's going to insert here at the angles of the corner of the mouth. And minor is going to insert up on the upper lip on each side. So this is a great example where I said learn what each one does by what they say they do, not by what it looks like they're doing. When you say draws the angle of the mouth superior and laterally, he's not really doing it in the picture that we're talking about. Major brings the angle of that mouth up this way and this way, as in he's smiling. Minor raises the upper lip on each side, and so minor's job is like almost bringing it this way. So most of what he's doing in the picture is looking like he's using minor. But for textbook study, and you say, well, what muscle is responsible for the action of smiling? You would say zygomaticus major. That's what pulls it out there. Okay. This one has two different muscles. Don't worry about which one innervates which. Just know that there are two branches, zygomatic branch and the buccal branch, that innervate zygomaticus major and minor. Did you hear what I said? Is don't worry about, like, well, does one of those innervate major, one of those innervate minor? I don't care. They're both innervated by zygomatic and buccal branch, okay? Kind of simplify that a little bit. Has anybody looked at the muscle chart I built you? Yeah, not yet. That's fine. Remember, any chart that I build you for muscles as we go through this is like the cranial nerve chart. My muscle chart is 100% correct. And if it's not, that's on me. If you find a discrepancy there between my muscle chart Excel and the slides. I took out, I'm pretty sure the muscle is pretty basic now because I took out on that Excel all of the origin insertions, and all you're seeing is the action and innervation. But I promise you this, if you, not so much in this one, really when we get to upper and lower extremity, what you're going to see is we go through compartments. And I've set up the Excel so that it says, has a heading on it, on each section, and they're color coded, so it helps to separate visually. And it says, when you say the anterior compartment of the arm, but they're in the order that we're going to talk about them in the slides, exactly. And so every muscle will be listed there, its action and its innervation. And I promise you this, if you pull up that, because when we get deep into the upper extremity, you're going to be like, oh my goodness, there's so many muscles and there's so many innervations. And when you see them in the chart, like I built, you build your own, you'll be like, well, everything in that compartment's the same one, the same nerve. And visually you can see that. Otherwise you'll get overwhelmed with muscles. Sorry, I thought about that because we're just starting to see muscles. Okay, levator, labii, superioris. Go back to naming tracks. Let's use our words. Levator, that means it elevates something. Labii, referring to the lips. Superioris. So the upper lip elevator. Just has a fancy name. It's going to insert at the angle of the mouth and all around the vicularis oris. Remember, that's the muscle that surrounds the mouth. And its job is to raise or elevate the upper lip. So that means that this one is going to help with zygomaticus minor. It's going to raise that upper lip, expose your maxillary teeth. And it is zygomatic branch. Same thing, the lower lip depressor, depressor levi inferioris. We have a lot of these to go through, so a lot of muscles of facial fascia. Depresses the lower lip, brings it down. It's down here close to your mandible, so it's mandibular branch. The depressor of the angles of the mouth, depressor anguli oris. You have to use that. If you're not used to these muscles, I know I've said it many times before, you gotta use generic language. It locks it into your brain so that when you see it, because you think, well, yeah, I'll always, if I, depressor anguli oris. It's easy when it's one word on a slide. It's harder when there's 5 answer choices, right? They all start running the same when you're going through. That's why I say, as you say them, kind of just say it in your head, like depressor anguli oris. All right, the depressor of the angles of the mouth. Right? And that kind of tells you what it does, because it draws the angle of the mouth inferior and lateral. Remember, I said a lot of them inserted the angle of the mouth. So that's going to draw that down. Kind of like your sac. It's also by the mandible, so that's mandibular branch. Orbicularis oris, that muscle that surrounds the mouth, that means it's going to insert everywhere around the outside of our lips there, surrounding our mouth. It's the sphincter type of muscle. It says skin at the corner of the mouth, fine. It's all the way around. It closes and protrudes the lips, like you're compressing your lips together, like you see him doing in the picture. It also helps you when you're compressing the lips during speech. You're opening your jaw, you're moving your actual lips, so it helps to shape them during speech. It is considered buccal branch. I often just kind of state those because there's no easy way to do it other than memorize them. Other than look at where the muscle is. You know, we can rule out it's probably not zygomatic, and it's definitely not temporal. Probably not cervical. You see what I mean? That's how you use these to narrow down. Buccinator, when you look at this muscle, it inserts into orbicularis oris, and its job is to help with things like whistling, blowing, sucking, draws the corners of the mouth laterally, right? And really it assists in helping chew also. So this individual is puffing their cheeks out, but orbicularis oris, buccinator, when it contracts, if you're chewing something in your mouth, like your burger, that's that area sometimes you're going to say, oh, I bit my cheek. That's because that muscle is pushing that food to keep it between your teeth so you can grind and chew that food. Right? So that's the job of buccinator. But it's not a muscle of mastication because it has nothing to do with moving the jaw. And that's the distinguishing fact between them. So if you say, well, temporalis, masseter, your medial and lateral pterygoids are the muscles of mastication. And then you get confused later and you're like, wait, buccinator's talking about assisting with mastication. Why is it not a muscle of mastication? It does assist, but it does not have the ability to move the jaw. That's why. And it is buccal branch. I gotta go. I'm thinking of. I was in seeing the dentist. I told you all this, and I asked them, "Do you say buccal branch or buccal branch? How do you say it?" You know, I told you this before. And they said buccal. But now I'm looking back and going, well, everybody says buccinator. Shouldn't it be buccinator? Going back to the question. Next time I see it. I don't know when that'll be, but I will remember the question. Rhizoras. What does he look like he's doing? Smiling. Yeah. So that looks mean, more like he's smiling in the picture we saw smiling. Right? But that's not Rhizoras. Rhizoras' job, he's grimacing. We need a new picture, because that's not a grimace to me. He looks pretty happy there to me, but the book has it in there. That's why I say you just study what textbook they say they did. Rhizoras inserts its anglet mouth, and unlike Zygomaticus major, that's what we're going to compare it to. Rhizoras draws the mouth laterally. But remember, Zygomaticus major draws the mouth superior and laterally. Right? So even though he's got kind of a smile there, that's not the job of Rhizoras, and it's innervated by the buccal branch. So he's going to grimace. You're getting close. We don't have too many more of these. Mentalis. Mental meaning chin. We already know that the chin is your mandible, so that gives us our mandibular branch. And so all we got to figure out is what it does. Well, it elevates, I'm going to draw kind of a circle here. It elevates your lower lip and pulls the skin out, as in your pouting. Right? Bringing that lip up and out. I'm pouting, I'm mad. I did not get the toy at Walmart, that kind of thing. Platissima, right, is that muscle you see in the UFC. They're spinning around the ring, they're popping that up. You can see those muscles pop up. Platissima, I always think of that when I see the tight in your neck, real strong neck muscles there. It inserts on the mandible and the muscle and the corner of the mouth skin. It inserts all the way along here. But you see that this muscle itself is down in here. So it can help depress the mandible, even though it's not muscle mastication either. It does somewhat help you. It's really pulling the skin down more than the jaw. And then it is cervical branch. So that's good because most of the muscle is down in here, in the cervical region. Just has a funny name. Orbicularis oculi, talking about the eye now. So we have orbicularis oris, now we have oculi. This is going to be going around the eye. So you would say its action, it closes, right, the eye by depressing the upper lid and elevating the lower lid. So you can close your eye. Remember, there's a separate muscle. I put it at the bottom so you remember that. That levator superior, palpebrae superioris was that muscle that raises the eye. It's the muscle that's responsible for your absence seizures when you're sitting there looking at me. Right? It goes back to that one. But orbicularis oculi is close to the temporal and the zygomatic, and it gets both branches. And then the last one is superciliary. Corrugator superciliary. So if you want to look at the insertion along the skin of the eyebrow, it's going to draw your eyes inferiorly, or the skin there, inferior immediately this way, as in your frowning. Say what? It is facial nerve like all the others, and it's up by the temporal region, so it's temporal branch. So that's all of the musculofacial expression. Notice some of it I just kind of rolled through because at the end of that presentation, most of what you can see is me telling you, learn if it says frowning, which muscle technically does that. Other than that, it's a lot of memorization, right? It's going through. And the only I can help is go, well, ask yourself where it's at before you answer its innervation. So there's only 2 or 3 that are confusing when you go, wait, it has both? Right? So look at them that way. That muscle. Sorry, I just saw this over here. This is Dr. Walters. So, have y'all seen the carnival uproar? No, you're studying micro, okay. The cruise ships. I'm stuck in a loop on Instagram where they're feeding me crazy carnival tours. What's that? Yeah. Never heard, I mean, I'm being honest. I never heard of that in my life. And that's because I live in a separate world. There's a lot of things I do y'all never heard of. But you can't take the fan on carnival anymore. Can't have a fan to dance the boots on the ground. Get out of there. Let them take the fan. mean, it's a block party up on the deck in all the pictures at least. But they were dancing around, and at some point in the song, everybody, I just watching it going, oh wow, I wouldn't call it crazy. They're partying on the deck. There's just a lot of people dancing to things. But then they break in, there's a song going, and then all of a sudden out of nowhere, I'm in the video, and I see them go. You know, they make a sound with the fan. I'm like, really? Sorry, I saw that. I'd say let them take the fan. Yeah. Well, of course, I wouldn't be upset if he said I can't take a fan, but they were talking about getting rid of the drink package on Carnival. Like, nobody's going to go on Carnival then. Get rid of the drink package. Anyway. And then I heard somebody say, well, they may just limit it to you can only get 15 drinks a day. I'm like, 15. Because you know, if you're like, now I don't drink a whole lot anymore. I won't say I don't, but I rarely drink. But 15 in a day, in my day, you know what I'm going to do with those 15? I'm not drinking anything weak. Right? I'm going for as hard as I can get if I only get 15. 15. Most people are terrible. Alright, that was our digression. Carnival Cruise. I like Royal. Going in twice. I like Royal. Neck muscle. Then we'll take a break after the neck muscle. So, Platissima is considered a neck muscle and a muscle of facial expression. We will look some more of that later. That's not real important to figure out the rest of this picture here. We're going to spend more time on sternocleidomastoid. This is a muscle that has an origin on the sternum and the clavicle. It has a clavicle attachment or origin, and it has a sternal attachment. And then it's going to insert into the mastoid. So if you contract both of these, now we already know the nerve innervation because we studied that cranial nerve. Remember sternocleidomastoid was innervated by cranial nerve 11. So if we picture these neck muscles, if you flex or if you contract both your sternocleidomastoids, that's going to pull your head into flexion. But if you contract one, it's going to flex and rotate your head towards the opposite side. So if I'm contracting this sternocleidomastoid, I'm looking over, like I'm checking track. So it rotates it towards the opposite side, and you know, they call that laterally flexing. If you don't know head motions, you can say flexion and extension. You have rotations, but then you also have lateral flexion. Bring it ahead. And most people don't have a whole lot of lateral flexion that you can measure. People who have excessive, if you're measuring lateral flexion of the neck, if you ever have the opportunity, I mean, I did that in therapy, I didn't do it as PA. What you'll see is you got to make sure people keep their shoulders down. Because most people will tell you they can touch their shoulder to their ear, and they can't. They can bring their shoulder up to do that, right? So I can't even do it without doing that. But some people say, yeah, I can tilt my head all the way to my shoulder. No, if you watch them, they're bringing their shoulder towards their ear. It's a goniometer measurement type thing, not the calculator. Right. I say that. I mean, that sounded negative. I mean it negative. I'm just saying it's not something we have to learn here. The scalene muscle group, similar to sternocleidomastoid, is that these are going off of the uppermost ribs and inserting here along the cervical vertebrae. So they do the same action. They flex and laterally rotate the head. Most of the time when you talk about these, you're going to talk about the scalenes and forced inspiration because they are a muscle, an accessory muscle of inspiration. They're very close to the spine. The golden rule there, any muscle that's ever close to a spinal nerve is probably innervated by spinal nerves. So in here we see C3 to C8, great. The cervical spinal nerves innervate scalenes because they're right there by them. Forced inspiration, if you've ever seen somebody in an asthma attack, especially a child, you will actually see the scalenes popping up, kind of flaring. You know, it's like if you take a good, quick breath and try to make those pop up, you can't. The asthma attack's the most commonplace I've seen. Or actually, I would think of after like a PT test, somebody really just finished a hard run, they're breathing hard, especially if they're out of shape, right? You start seeing those scalements pop up. I say out of shape only because some people run through the finish line and they're like, hey, give me a cigarette, let's go have coffee. You know, and then there's me, who I just pushed it that last quarter mile, you know. Oh my God, I'm gonna die. Don't let it. I'm making fun of myself because I really wasn't this person, but I always love the people yelling at people like, don't lay down. And the people who they're telling to not lay down, what do? Forget you, they're out, right? They're laying down. Don't lay down. I love the people and they'd smoke while they're running if they could. Sergeant majors back then, first sergeants, they're running along. E7, as soon as they finish the run, they're like, cigarette in the mouth. Golly. Can't do it. Muscles in the anterior neck. We need to take a break. We're not going to get deep into these, but I'm not going to finish the slides on these. So that's a good spot. Let's take a break.
They went to the after treatment that thought you could no, I don't know where these are how to treat them. But the other ones are so I give them a try. They're doing questions. That's on from there.
Appreciate your time. Let me think about this.
She also said that extra large Austin discs. Yeah, it's the last one. It's pretty blue. It's just all forces. They only want to keep the ones that want to. It's cool. Yeah, like the unit itself is neat. Oh, that's really cool. How they do it is you're there, you get sent to it, they keep everything in-house, so they really send you whatever the call is, you just the job. It's like you're mason, that's all barrier, like as a worker, really send you to the school, just say you go back and they big hospitals stuff, they make all this stuff. The horses like look great, they're show horses. If you don't maintain them, they're gonna if they show if you don't take care of them, it's going to show. $900 million. I used to make the coffee. Just nope. There's nothing other than a liquid sugar on no water. Once I study, I'll know. Is that super high. If you're here, flexing, right? Just start yeah, you can get over bones. I was thinking today, we try our hand at one of the tests, something that you've done. Just see where we're at, and then we can hit some more. What's your first test? It's at one. Was it? Bio? That's why I like you're out there. That's kind of what I'm going to be able to do. I'm not going to any test yet. happen. And then you can just do the general memorization. That's all the videos. Especially with other decks. And having like gone through and like redo them all and everything. And you be like, I just like see what I meant. Just remember all the stuff. See what I can do. You don't have to think about it. It's in the brain. And then once you have your ADD call, the questions, I think that's the big thing. The questions. And then like really hone in. So that's I'm doing all those back so good. So far that's helped. I wanted to try it out today. Get through. I was telling him well, because they wouldn't be dude, that was even I still need to go through and write down everything with vaccines and everything that's biological. Which one is there vaccine? All these It's like when I'm looking at now I see it, but there's so much random stuff. And it's not even mentioned once, but it's mentioned. Yeah, it's on the picture. It's not even on the cluster part. I hate how I'm afraid because she had the way her notes are big. Usually when things are big fonts, those are big top. Yeah, and it's fonts underneath things. Usually those are smaller fonts, but then you see them and it tells you. Oh, that's not the both the other ones that you see are not. That's what you're being like straight. You gotta use this it's catalysis is already giving you like okay. I honestly don't think there's a lot. Like, I don't think there's a lot. You know, then I can like, you know, like how another question. Yes, wait, oh, these are 40. These ones right here. Oh, yeah, so these are the. So Anderson, I swear, the ones that I remember on there. They cannot degrade sugar like again. But that's like a lot of them. Yeah, there's two. Which one? Two. That's probably smart. No, There was some hype of this. Again, you get paid too. Off of there, but
It's like the brand of like these are
he's
got
awful.
like
You gotta go first because there's so many of them that are like, which one is that?
They do the same, they do the same thing.
He's gonna hit that bus.
It's just like one person versus it's like all three of them.
That's what we always look for.
I just memorized the major
How do you study? You study this.
traveler.
I was talking to my dad the other day. You know what he bought? A&P shotgun. It's really on Palmetto Cigar Break. It's $11 for an A&P black. Yeah. So he saw it from his buddy. His buddy is yes, I found out. His buddy is a smith who makes guns and everything. He says that it's a Chinese made that's made in the same factory that all the Soviet or the Russians had made. So it's a good part of the empire as well. He's like, you don't come to the firearm magazine, but I went ahead and it adapted for he's like, I have it for sale for home defense. That's a lot of home defense. I think it's I think it was 3 inch, but sometimes it's 2 3/4.
Because she said the OHA.
I was thinking, I told him something that we could do. No. Hunting, go do, imagine hunting turkeys with that AK, or just showing up with that AK. Shit for a turkey. It's just supposed to be a shock.
Right before I walked in the doors, students stopped me. They said, I'll never get it. They said, I'm looking back on last semester and I still think your class is like the hardest one. I never get that. I never get that. And I'm not being sarcastic. I'm like, hey, the hard part is not me, it's what's the hard part I actually want? Memorizing. It's a lot of memorizing. But then they did agree that, yeah, there's that little thing that you talked about that I thought was worthless. Students are honest with you after you no longer hold grades over them. But they don't know I could show up to grade them on their homeland. I'm just kidding. They're like, that little thing that you talked about showed up on a test and it helped me to get that question because I knew what that was, even though you didn't explain everything about that. I'm like, well, that's the downside of A&P 1 is there's a lot of things that I bring up, these little things, that, especially if you're prior medical, that you're like, we don't need to know that, and you probably don't in life as a kid. But I've said this many times, I know, but for the classes here, you do, and it helps you. And that's you'll never understand it while you're sitting in the class, but hopefully by the time you're a senior, you see some of the value in what I covered. So, I never take it offense when they say anatomy was hard because it's a lot of memorization. It is. I know. Somebody else told me at the break yesterday it just seemed like a bunch of gibberish to me. Like, I get it. I know. It is. It's a lot. There's a lot of holes in the head, right? I need you to know the ones that I told you, what goes through those holes in the head on the sides. If you come to studying that in a week and a half, and you're like, I don't remember what he said about these holes in the head, and you see these pictures and you didn't write down what I was saying about don't do this, don't worry about this, come back and find me and say, because there's a lot of holes labeled on the head, pictures from yesterday. Ask me, is that one that we were looking at? No, we didn't even talk about that, I'll let you know. So, if you get past everything else, when we get towards mine and you're still confused about holes in the head, let me know. We'll figure it out. Or we'll come back in and go over it, whatever we're gonna do. Okay, there are muscles in the anterior neck along with looking at like platysma, but now we're separating, saying, well, what are some of the deeper muscles or more anterior muscles or posterior muscles that are associated with our neck? And the ones we're gonna mention are the hyoid muscles. There's suprahyoid and infrahyoid. These are muscles that attach to the hyoid bone, which is a free-floating bone in your neck. So the hyoid bone provides an attachment point for muscles that help you with things like elevating the hyoid to push your tongue up during swallowing, so it's an anchor point for the tongue. And the infrahyoid is associated with moving the larynx. So the only difference, I don't need you to know the muscles that are above and below the hyoid, other than knowing that there are suprahyoid muscles and there are infrahyoid muscles. The hyoid bone itself is a U-shaped bone. It doesn't articulate with any other bone in the body, which is kind of unique. It's horizontal and it has paired projections that we see here coming off. Alright, so it kind of sits up in. So it's suspended by ligaments, but it also has muscle attachments that go to that, or muscles that move the tongue, muscles that move the larynx. I do not need you to learn those. I gave you a picture here of them just as reference to show you. Here is the hyoid bone. And then you have muscles above that are your suprahyoid and muscles below that are your infrahyoid. Right on there. If you need to, I do not need to study and diagram out these muscles. If we were in nutrition or the dietitian's class, I made them learn that. They need to know the muscles of the tongue, right? They're going to be doing speech evals and swallowing evals. We are not as PAs, so we'll probably never really think about the individual muscles that are there. But I want you to know they exist. So those are muscles I'm not actually going to spend time on. Right. On the posterior side, these are muscles that we need to know and worry about because these are suboccipitals, and a lot of y'all and other people are having problems with their suboccipital muscles being tight. And so there are 4 small muscles, and they're not, a lot of muscles you have, bicep on one side, bicep on the other. They're not mirrored. There are 4, rectus capitis posterior, major and minor, and obliquus capitis inferior and superior. When we see them in place in the neck, we kind of blow that up. This is what they look like, where you have a superior oblique muscle here, and then you have an inferior oblique here, then you have rectus capitis posterior minor, and then major. It's slightly larger. These muscles are going to combine to do motions of the neck, meaning they can do some flexion, extension, lateral bending, anterior rotation of the atlantoaxial and atlanto-occipital joints. Those are joints associated with the upper part of your spine. The first 2 vertebrae form some joints called, they're synovial joints. So atlanto-occipital, occipital-atlanto are these joints that we find up in here. So your suboccipitals get tight and you start to feel that. And it's something I used to have a problem with. Actually, my suboccipitals used to get tight, cause me like headaches all the time. Right up until the point where, believe it or not, I broke my neck out on Missions baseball field. And after I broke my neck, the headaches went away. Go figure. You ever seen the movie Johnny Dangerously? Probably not. They toss paper, never mind. Nobody knows that movie. Okay, so those are your suboccipitals. If you're having problems with them, if you're having stress headaches, or your neck's tight and you got suboccipital tightness, they sell on Amazon. And I have one that I stole from Fort Benning's therapy years and years ago when I was there on active duty. I still have it. Because you can do a suboccipital release where you can have somebody, you lay flat and you take your fingertips and you put them at the base of that person's skull. You got a picture of this person is laying down. And you put them there and you're supporting their skull, pushing on the muscles, right? You've heard of like trigger points and release points, right? You're gonna hold your fingertips there as you hold their head, they're lying back. Eventually you'll see those muscles start to relax. They sell a pillow. It's called the occiput. It's about this big, like that. It's hard, like rubber, like plastic, and it has molded fingertips in it. And you can lay your head on that while you lay on bed and relax your suboccipitals. It's called the occiput, but they're not cheap. So maybe in phase 2, go over to therapy and get you one. Otherwise, if you need it now, get your significant other to do suboccipital release or pay $60 on Amazon. I don't know why they're so expensive. There are other ways to do that. Seriously, if you have suboccipital problems, come talk to me. I've dealt with it for years. Okay, we have to look at, remember we're doing regional anatomy. And so now we've covered the bones and we looked at the muscles in that area. Now we're coming back to say, okay, well, what arterial supplies are in this area? And we're somewhat familiar with them already. So when you look at the right side, right, we had that brachiocephalic trunk. Coming off of the brachiocephalic trunk, we have the right common carotid artery, and then we have the right subclavian. Okay, this blow up is looking at really what are the branches of the subclavian. And what's boxed in red is the only ones I want you to key in on. Because coming off of the subclavian, we have our right vertebral artery. And then we have our internal thoracic. Okay, so I didn't box off everyone on that picture because those are the ones that we're going to see later. We've already seen excuse me, the vertebral arteries, because the vertebral arteries go through our intervertebral foramen, or sorry, transverse foramen of our spine to go up through them. But then our internal thoracic is going to come back up when we look at the thorax, because the internal thoracic arteries come off of the subclavians and go straight down the sternum on each side. And we'll get back to the rest of that later, and I'll remind you of that. And so those are the only branches on here that we need to get familiar with. So arterial blood supply to the brain is very important, and there's an area just below your cerebrum but above your brainstem called the circle of Willis. Circle of Willis is very key to providing all of the blood supply to your brain. The way it's going to get its blood supply is using the vertebral arteries and the internal carotids. Remember the internal carotids yesterday we said went through the temporal bone when we looked at its projection, the Petries portion. You had the internal carotids and the jugular that went through that bone. Well, they're going through there to get to the circle of Willis. So you have vertebral arteries that go through the transverse foramen of the cervical vertebrae. That's why they have those holes in them. And they're ultimately going to come together once they go through the transverse processes, and they will join together and become one artery called the basilar artery. Internal carotids are going to come up and go to the internal. Let's look at it on a better picture. So here's your transverse foramen. And so your internal carotid comes off your common carotid, and then if you look at the blood supplies, you're going to have the right external carotid and then the internal. The internal is going to go up and into the base of the brain. It's where the temporal bone. And then your vertebrals are coming up on each side back here. So if we look at this picture on the right, which is kind of smaller, I think I have a blow-up cover. But just for now, the internal carotid, now you got to remember that we are looking at a view like this. Let me make sure I orientate it that way. So we're looking at it in that picture like we're here. So that we have vertebral, the circle of Willis is going to sit here. It's a blood supply. And so in this picture on the right, you're looking at a view kind of like this. And that's why the reason I mentioned that is these internal carotids, I don't say, are coming up into the circle of Willis. Problem is we're looking at an inferior view. And now the brainstem's broken, you know. There we go. Somebody had fun putting that together. Alright. The vertebral arteries are coming up and uniting to form the basilar artery. And that's how we get dual blood supply to the circle of Willis. So the important part of this is the circle of Willis provides all of the blood supply to the brain, not to the face, not to the skull. It's specifically providing blood supply to the cerebrum. And because of that, it's important that it's an anastomosis. Anastomosis is when like two arterial supplies connect together. So all of the blood coming through the vertebral arteries and all of the blood coming through the internal carotid arteries is meeting up to form the circle of Willis. There's a blood supply to each side. So that if we had a blockage anywhere along the circle of Willis, we would still get blood to the brain. So it makes a little more sense. I'm going to use the picture on the right here because it's kind of color-coded. Here's your vertebral arteries coming in. They will unite to form the basilar artery. Here are your internal carotids coming up in pink there. Just the portion that the pink portion is the internal carotids. They're going to be connected to make the circle of Willis. We're going to see that there is, as these blood supply comes in, there is a posterior communicating artery on each side, and there's an anterior communicating artery. So all of that, you picture a circle. It's called the circle of Willis. Outside of that, I don't need you to know. I need you to know how the internal carotids got there, how the vertebral arteries got there. After the blood supply leaves the circle of Willis, it goes to a named area of the cerebrum. So I don't need you to memorize those. Middle cerebral, anterior cerebral, they all have names. We're not going to go out that far. Right? Just look at what parts or forms of arteries of the circle of Willis. You will definitely hear about that again. That is an area where if you've ever seen somebody, they're 25 years old, high-speed basketball player, and they just drop dead on the court one day, they have an aneurysm. Right? Sometimes that can be up here in this circle of Willis. Right? But if you had a blockage on like a posterior communicating artery, you would still get blood supply to the whole brain because of the dual blood supply to this area. It definitely will come up again. And the external carotid, though, is what everything on this picture is concerning the external carotid. And so I mentioned a lot of them, but the fascia is very vascular. And so if you look at the different branches, we have a facial artery, comes off of there, superior and inferior labial arteries. The only ones you need to know on here are the ones I boxed. I know it is about all of them, but look at where they're going to. Maxillary artery, occipital artery, you have your posterior auricular, and meaning we're up behind the ear, internal and external carotid. So that provides the blood supply to all of the face, and very extensive. This facial artery I'll bring back up when we talk about muscular triangles of the neck. And even though it seems like I just talked about it yesterday, I'll tell the story about 4 o'clock on a Friday at McGill Air Force Base. Unless I've told it already, because I cannot remember, semesters run together so much. Hey, if we're going to bring blood supply to the head, we need to get that blood supply away. We need a venous system. One of the venous systems we already talked about. When you look at the external jugular, and I'm only going to use one slide on this, the external jugular that we see right here is draining blood away. Do you see these real grayed out kind of veins up in here? Anybody remember what those are probably called? Yeah, the dural venous sinuses that we saw in neuro when we talked about blood flow up there. The dural venous sinuses drain into the external jugular. And when we look at, into the internal jugular. When you look at the rest of the face, it drains into the external. So let me recap, because I misspoke there. The dural venous sinuses that we saw up around the cerebrum will drain into the internal jugular. The external veins will drain into the external jugular. That's how we get the blood supply away. And we can't leave out with saying, well, what about the lymphatic in this area? You've seen this picture many times. You'll continue to see it. Looking at thoracic drainage. So once again, if you don't know this by now, the thoracic duct is on the left. Right? It forms at the junction of the left internal jugular, left subclavian veins, and it's found over here. It's very large, and it drains all of the area in green that we see over here. The right lymphatic duct is much smaller, and it only drains a portion, the right half of the head, thorax, and right upper extremity. It's found at the same location on the right, though, between the internal jugular and subclavian veins. Now, why they had to call it the thoracic duct versus the left lymphatic duct, I don't know. Innervation of the head. We've already seen this too. So when we were looking at cranial nerves, we pulled up this picture and we said, well, and I walked out a bunch of the stuff that was written on that last one. All I need you to recognize here is, once again, cranial nerve 5, you got a big V on your face, does cutaneous innervation, and you have those 3 branches, the ophthalmic, the maxillary, and the mandibular branches color-coded here. So that shouldn't be new information, we've seen it before, but there it is again for this section. And because of this, we also have dermatome. So cranial nerve 5 is the dermatome for the anterior portion of the face. So now we're going to talk about something new and add in, well, C2 on the back of the head, the area of your occipital protuberance or your drill sergeant's bump, right, that's actually the dermatome for that area is C2. Sorry, black on black, get marked there. C3 is called the gentleman's collar. Like if you watch the old TV shows, I don't know if there's a new one, what's the Gilded Age or something? Do they wear those? I don't know. It's back a long time ago, people wore very high collars right up to their neck. So they called that a gentleman's collar. That's the area of the C3 dermatome. Continuing with nerves in this area, we have the cervical plexus. Right? We're not going to learn and label, I told you, cervical plexus, brachial plexus. We just know they exist. We're going to talk about, every time we look at a plexus, I'm going to mention the nerves that come out of it for us that are important. like from cervical plexus, it's gonna be very important that the phrenic nerve comes off of that. Okay, so whether or not you can ever label a cervical plexus, have I told y'all that before during neuro? When we brought up, I'm losing my mind today, trying to remember where I'm at. But the cervical plexus in general is serving the neck and the upper shoulders, part of the upper arm there. But an important aspect of that is that phrenic nerve on each side, there's two, one phrenic nerve on each side that comes off of the cervical plexus to innervate the diaphragm. And once again, if we damage the phrenic nerve, we're going to damage the innervation to our diaphragm. We talked about it earlier and said, well, C3, C4, C5 kind of tying together, C5 to stay alive. But if you're lower than that, remember I gave you some general saying, somebody could be a C4 injury and still be breathing after they've had assistance for a while. But now we're down below it. So the phrenic nerve is all or nothing once you get below that. If you sever the phrenic nerve anywhere below that, you lose that side of your diaphragm's innervation. And breathing stops. Two other things that come off of the cervical plexus helps explain the backside of our earlier diagram. The lesser occipital nerve, the greater occipital nerve. Greater occipital, lesser occipital, and the greater auricular nerve. I'm going to back up so we can look at this. It goes back to this picture. Now, if you looked at the area and you find it, this green area would be the greater occipital nerve. Well, that's great. It's backed by the occipital region. So you would say that if somebody was describing that they had a loss of sensation to their head, you would say, well, does it encompass or include the drill sergeant's bone, your external occipital protuberance? If that area is non back there, we know that that's a problem, that's your greater occipital nerve. So you can kind of draw out and define these regions. The lesser occipital is in front of that. So you would say like the lesser occipital nerve is kind of above the ear, up into your hairline. It's posterior to the ear, and it extends somewhat down into your neck there. I'm describing the orange one here, tan, whatever color it is. If you were going to describe the greater auricular, you would say, well, that includes the area below your jaw, anterior to the ear. As we see here, anterior to the ear, doesn't go back there. I didn't mention a key landmark when you say lesser occipital, right? You said I've lost sensation over my mastoid process. That would be lesser occipital. If you drew a line straight down from the ear and came there and along the jawline, that's all greater auricular. So that's how you can find them out. Look for landmarks, because they're going to lose the whole dermatome. So they're going to be able to describe. It goes up into my hairline. It does not, let's do one and say, well, patient comes in, says they've lost sensation, and they point to their head, they say, I can't feel anything here and behind my ear. Okay, great. Does your loss of sensation include the area underneath the jaw? Are you numb here? No. We just ruled out greater auricular. Okay, it's back there. Are you numb back at your drill sergeant's bone? No. Okay, so it's not greater occipital. Now you can narrow it down and say, well, that's the lesser occipital nerve. It's the way to distinguish between those. Okay, back to where we were. One of the enjoying parts of suboccipital tightness, those muscles getting tight, is that just like the piriformis goes close to muscles in the hip, greater occipital nerve also goes very close to obliquus capitis inferior muscle. That was one of our suboccipital muscles. Sometimes it can go through that muscle and it gets entrapped. So most people, when they have suboccipital tightness, they may get that band and kind of feel the pressure on their head or a headache possibly, and that area hurts. somebody with greater occipital nerve entrapment and their suboccipitals get tight are going to start to feel not only that band feeling, they're going to sometimes have a lancetating kind of pain, that nerve pain shooting over the top of their head. Right? So if you're having that, that's a greater occipital neuralgia. The answer is to help your suboccipitals relax. Right? The blood supply is there too, so you can see here, a lot of those people also report that they feel like a pulsation back in their suboccipitals. Killing y'all now. First hour, y'all were a little bit with me. Now y'all, I'm losing my crowd here. And I'm just rolling on. When I start to roll on without digressing or anything, I become monotonous. When I become monotonous, I start seeing y'all dropping out like flies. But I have nothing to say as a dietitian. You know that's unusual. I don't know. I learned to use ChatGPT, whatever you say. They need to change the name. It's hard for me to say. I was using that a bunch this weekend for the first time ever. That's pretty cool. About it. It didn't solve anything for me though, but it did build a chart for me. And then I made some funny pictures. Oh my goodness. I had to do baby man. That was pretty cool. Didn't look anything like me. He was like a good looking kid. I didn't look anything like that at that age, buddy. It took me a long time to get this good looking. Okay, here we go. TMJ. See, I wound up saying something funny. TMJ. The only movable joint in the head. Is that true? That's what everybody says. That's not true because what is another joint that moves in the head? Yeah, thank you. Y'all were listening to me back then. The ossicles. But technically, most people say it. You say, what's the only movable joint in the head? If you're on Jeopardy and they ask you that, even though you should be very smart if you're on Jeopardy, right? They wouldn't say ossicles. They would say, well, the TMJ. Right. So the mandible articulates with the temporal bone to form the temporomandibular joint. We can have TMJ from so many different things. I don't have TMJ, but I probably should, because I told you once I hit a windshield and it fractured my jaw and it broke just below where the mandible meets the temporal bone, just below my TMJ joint, and just fractured it straight across. And I said, you know immediately, because your bottom teeth should not be on the outside and upper of your lower teeth. And that and the pain was excruciating. Anyway, I remember looking in the mirror out the door and pulling my jaw back down. And at the same time, half my lip was tore off, so it's just bleeding everywhere. I just remember looking and going, oh, that sucks. This sucks. This hurts. Then I had braces on at the time, so they just wired them together. 6 weeks with my mouth wired together with wire, and then I learned what you got to eat to stay full, though.
How did you sustain that?
You really want to know the story. I was riding with a kid in a 1984 Blazer. Just got his license the day before. We're driving to Arlington, Texas to go over and see if we can see any girls at University of Texas in Arlington, which has sorority houses. You're getting the whole story. Just being flat out honest. It was a Saturday morning at 9 o'clock. We were not drinking. You know, when you're drinking, you probably wouldn't get hurt. But, that's what they said. But I'm riding in the passenger seat of this old Blazer. There's a guy in the back seat who doesn't have a seatbelt on for one thing. I had my seatbelt on. We're stopped at an intersection. You got a picture. There's a road going like this. This road's going both ways. We're sitting at the intersection. There's a house right over here we're about to go to, and there's oncoming traffic coming this way anyway, right? I have to describe it because first day he really had his license. As we're sitting there, the guy in the back seat says, "Hey, let me sit up front." You know how it is when you're a teenager. Everybody wants shotgun. Anyway. And I said, okay. I unbuckled my seatbelt. And I said, oh, wait, we're just going right here. But what I didn't know is this dude starts to pull out and sees the car's too close. So he floors this old Blazer. and he spins into this lane, I have to kind of describe it. And there's cars coming this way, so that car goes by, but he goes back into the lane. And there's another car coming. So if you've never been in an 84 Blazer, he does what you shouldn't do in those, he yanks the wheel. The wheel will spin completely like a Jeep would do. You kind of pull it and throw you that way. When he did that, we flew off the side of the road and hit a tree bigger than I could put my arms around. It was huge. And they said the last thing they heard was me. I was kicked back with sunglasses on at the time. And the other two guys in the car said, all we heard was you go, dude, a tree. We used the word dude a lot back then. I said, dude, a tree. And then we hit that tree and I hit the windshield. I didn't have a seatbelt on. The dude in the back bent both seats forward. The guy driving hit the steering wheel, bent it both ways, and knocked out his teeth and broke his sternum. It was a nice wreck. And we found the girls at the sorority house. They came out to help us. And I'm standing in their bathroom bleeding profusely. Anyway, they also hauled me to the hospital. So. The other two went in an ambulance. They got help before me. I got there before them though. They wouldn't help us because they thought we'd been drinking. It was crazy. They wouldn't give me any painkillers and said we've been drinking. I'm like, I've not been drinking. I got to end this story, but the police came in while I'm lying in bed. And my sister had come in because my parents were out of town. And I'm laying there, and this cop starts asking me questions, and all I remember is thinking on mine, I'm done talking. I can barely talk anyway, because I'm not wired up yet. I'm just sitting there, no painkillers, my jaw's broke, and they're asking me questions. And I remember them asking how much y'all had to drink, and I said, nothing. They're all bull, blah, blah, blah. It's the 80s, so they could talk like that. And I remember just shutting down, and that's all I remember. My sister goes, no. You looked down and said, I ain't answering effing any more questions through your teeth. Because you're being an idiot. I'm not drinking. Anyway, it's kind of obvious. I'm glad somebody was there to see it. But I have nothing against, I didn't take that to mean that I have anything against police people. What I'm saying is I was in pain and I didn't want to answer those questions. But they left, this is 3 hours into it, and they still would not give me any pain meds. So they were convinced that we had to be drinking into the tree. Anyway, that's the whole story. I didn't break my neck. I didn't pick glass out of my head for 6 months. I'd be washing in the shower and it would come back up. And you'd knock it out of there. Broke my jaw. When you break your jaw, do not do what they say. They told me, hey, take your food and put it in a blender. Then you can suck it through your teeth or something. I'm like, what? Try it. SpaghettiOs are bad enough on their own. But when you boil them in a blender, they taste nothing like they did before. They were talking about, she literally told me blender, put a hamburger in a blender. Are you kidding me? But if you ever find yourself in that situation, at the store, believe it or not, in the cake section, they sell chocolate fudge icing in these nice containers. You can get that through your teeth, no problem. Because soup will not fill you up and you're going to be starving. I ate a lot of chocolate ice. I know that sounds silly. It sounds gross. Necessity changes what you'll do in life. Because when you're a teen, 19 and hungry. Here we go. Sorry. He asked, don't put that one on me on the critique. He asked, put it on his critique. Okay. There's your TMJ. When we look at the structures, I have them color-coded so that we understand. We all pretty much know that we're going to see people with TMJ, which lends more importance to it. Here is the temporal bone, and this is actually the portion of it in yellow here line is called the mandibular fossa. So the head of that mandible can go up in there because in green, we have the head of the mandible. In front of here, we have another important area in blue called the articular tubercle. And in purple, I won't draw all over it, that is an articular disc. And when you say articular disc, you could mean the disc that's in your knee, you could mean the disc that's in your TMJ. It's a disc within an articular region. And so in the temporal mandibular joint, they just call it an articular disc. They didn't give it a fancy name. In the knee, the articular discs are called meniscus. But they're one and the same. They're both an articular disc. We just call them menisci in the knee. So that's how that joint is set up. Now we come back and say, well, okay, well, there's a temporomandibular joint. We're moving our mandible. These are the muscles of the TMJ. So now we have a different classification that says TMJ muscles. Well, what other classification could we call the TMJ muscles? Muscles of mastication. They're the same exact muscles we saw back there. Instead of calling them muscles of mastication, we're calling them muscles, TMJ muscles. They're still muscles that move the mandible. Okay, the reason I said like the auricular tubercle up here is important is when the TMJ joint does its function, it actually moves forward and down when you open your mouth. Okay, so it goes out and down. And some people can really tighten their jaws and kind of pop that back and forth. Right? And you can dislocate that area. Many things can cause TMJ pain. From your teeth being off, to, all sorts.
I got a question.
Yes.
Does that area commonly like degrade over time and become arthritic because due to the friction?
Of course, yes. I mean, it's a good question. Does that over time become like? Are you prone to TMJ the older you get? Yes, and with considerable, friction, things that you might do in life, or you like I should in my lifetime develop TMJ, right? I have an injury very close to that area, but I haven't. So it can become arthritic, yes, like any other joint. And that's some people's cause of pain for it. Other people, like my daughter, she's had braces like 3 times. She's got perfect teeth, but she went back in and had them because of the braces. And they try to move her jaw around. And a couple of classes ago, we took her in. She was having TMJ pain. And they said, wow, your teeth have moved. Right? So we're going to redo these braces. And she's still doing this treatment over at Lackland, where she goes in once a month. Except for she didn't do the treatment they wanted. We went to 3 different military providers to ask about TMJ, and what they told us, everyone's plan, all of these were surgical people that wanted to do this, and they wanted, one person gave us a plan and said, we're going to go in and pull several teeth, and then move that around so that it sits better. No, you don't pull good teeth, ever. No reason. You're not pulling good teeth out of it. And then so they came back and they got ticked at us. 2 different ones told us that. That's the treatment. And then they went back into these same doctors. The chief came over and explained to us that, okay, you don't want pulled teeth. Here's what we're going to do. They're going to go in and flap the skin of her face and cut out part of her mandible. No. You ain't doing that either. And they got pissed. I told us, well, we're not going to see you. If you're not going to do the surgeries that we're recommending, we're not going to see you. I'm like, well, we're just not doing that. We're not pulling teeth, right? And we went to a civilian, and I'm not down in military here. I went to military, just a military, because that's our free health care. So we went to a civilian, and they actually saw us and said, I don't know what they're talking about. Sent us, go back to these military folks at Lackland. And it's where they train a lot of these people. And they were like appalled, like, well, they only wanted to do surgery because they don't get to do these very often. They wanted to do it. No, you don't have to do that. We can adjust. And they're doing manual adjustments for things and stuff. And they're like, never let anybody do that surgery to you. I'm like, if you don't know this, surgical residents like to do surgery. So some surgeries you don't see very often. When you get that opportunity, I think that's what they were leaning towards. They wanted to do the surgery. Right. We didn't do it. I don't know why I told that. Muscular triangles in the neck. Last thing we'll cover today. Where are we at here? Oh, we're moving right on. Okay. Muscular triangles in the neck. So I won't get to tell as much of a story with this, but These are important. What I'm gonna teach you about is important. I didn't know they were important when I came through PA school. I still don't know how much I use them on a daily basis as a PA. But I do know this, there is a posterior and anterior triangle. They are broken down into subdivisions. Alright, well, when I was at phase 2, I went into general surgery. I've been in there for a while, so I've held my share of retractors, and I've got the close and the last layer of the skin. You're hoping to get to do things. They don't always let you. And general surgeons are different than other surgeons. They're all kind of rude. They're just, I don't know what it is. But I'm in there with the lady that you do not want to mess with, and she says, you know what, tomorrow, you go and study. We're going to do a thyroid surgery tomorrow. You go study about that surgery, and I'll let you kind of assist. And that's a great thing. You want to be on the list as assistant. Okay, great. I went home and studied everything about that thyroid surgery. I got in there, I didn't get to really assist anymore because I couldn't answer the questions. Because she started off with this. Okay, you went and you studied the thyroid question. We're already scrubbed in. You went and studied the thyroid questions. Okay, we're ready. You know, everybody's still getting ready. But while they're doing that, explain to me everything that's going to happen and what you have to go through and what you need to watch out for before we get to the thyroid. In other words, from incision to the thyroid, what is in the way? What is that? What's the danger there? What do we got to go through? And I'm like, holy crap. And what she was referencing was the triangles. Okay? So real quickly here, because we're just going to memorize what's in the triangles, and there's not that much in each one by definition. Posterior triangle has 2 subdivisions. You have an occipital triangle and you have a subclavian triangle that we see depicted there. That's the subclavius muscle, so below that. Here's what I want you to know about these. When you look at the occipital triangle, it has the occipital artery in its apex. Here we also see them reflecting the cervical plexus off of here. And crossing this, we have the accessory nerve. So if I was asking you anything, it would be what's in my boxes on these. Is, okay, the occipital triangle is a subdivision of the posterior triangle, and it contains the occipital artery, the accessory nerve, and cervical plexus. Don't label anything else on this picture. Stick with what's in the boxes. Okay? I don't want you to learn the landmarks. The books will tell you all the landmarks of these. I'm not going to teach you those. Okay, the subclavian triangle is named that way because it contains the subclavian artery and the subclavian vein, and it's superior to the clavicle. So sometimes it's called supraclavicular triangle, but it's the subclavian. The anterior triangles, subdivisions, I'm kind of going a little bit quicker so that I can tell you one story before we go on this. Has 4 divisions, 4 separate triangles. You have a carotid triangle or muscular triangle, submandibular, and submental. The submental triangle is below the chin, and there's one on each side. And it contains submental lymph nodes. That's all you gotta know is what's in it. Don't worry about the borders. The submandibular triangle is just below the mandible over here, and it contains the submandibular gland, the facial artery, and the facial vein. Do you remember the story I was talking about earlier about the facial artery is off of that external carotid, and the facial artery supplies a lot of the blood to the face. So you do not want to mess with it. But in phase 2, on like a Friday, of course the 2 PA students were still around, but everyone at McDill by 4 o'clock on Friday was generally gone. The surgeries are over for the day. Their ER is not a true emergency room, so anything big coming in, probably going off the Tampa General anyway. And at 4 o'clock, like 4 o'clock in the afternoon, this resident, not resident, I think he was first year medical. They didn't have residents. He was a first year provider or something. Either way, dude went to remove what he thought it was a lipoma and nicked the facial artery and just and it was bleeding everywhere, you know. Anyway, they had to call back in the whole surgical teams. And so it is, the reason I tell that is it's important to know what's in that triangle, because if not, you run the risk of some simple procedure like a lipoma removal turning into your career ending, you know. I doubt their career ended, but it was a big deal that day. Alright. Pay attention to what's in the triangles. The last two and then we're done, I gotta hurry. The carotid triangle, guess what it contains? Carotid artery. Okay, well it contains both. Common internal and external carotid arteries. It actually also contains the internal jugular vein, and then it gets busy. The vagus nerve goes through here, it's transient. Transient nerve means it goes through an area but does not innervate anything. And it has parts of the thyroid gland, and the larynx. And the last triangle here is the muscular triangle, which contains really their hyoid bones up here. So it's going to have those infrahyoid muscles, the viscera of the neck, right? Such as we're talking about other parts of the thyroid, the parathyroid glands, the trachea, and the larynx. There's a little bit of overlap between these two triangles and what's in them. So you just got to pay attention to that. Like, if you're going to key in on anything, the parathyroids are in the muscular triangle, not the carotid triangle. All right, I'm into y'all's time, so I'm just telling you flat out. On those triangles, I want you to know what's in the boxes. That's it. Don't label the picture. Don't go in the book and read about what borders. Just tell me what's in it. Can you recognize that the facial artery is in the submandibular triangle? And of course, their divisions. That's all you need to know about. All right. I'll see y'all tomorrow morning.